Hello and welcome to Chapter 11 in Electronic Health Records. We're going to be talking about clinical decision support systems and quality improvement. Now, before we dig into the chapter, I just want to point out on 293, it talks about EHRs in the news. And I think it's pretty neat because it's talking about the NFL, the National Football League. And if anybody's familiar with the National Football League, there are 32 teams. Now, what they recently did was implement an interoperable electronic health record. Now, no matter which of the 32 teams you play for or where you are physically playing, they can access a comprehensive health record on each player. They can see the patient's history, they can see their medications, and one thing unique to the NFL is they have video footage of injuries as they happen. So I thought that was pretty cool and just wanted to point that out on page 293. Now, this entire chapter, we're going to be digging into clinical decision support systems, or CDSSs. Now, starting on slide number 5, over on page 295, it talks about how there's a number of definitions for clinical decision support. Well, the one we're going to focus on is what CMS says, and they're saying this in relation to the meaningful use standards. So they define a clinical decision support system as health information technology that builds upon the foundation of an EHR to provide persons involved in care decisions with general and person-specific information, intelligently filtered and organized, at point of care, to enhance health and healthcare. Now, the simplest rendition of a CDSS is any tool that helps the healthcare provider make a better clinical decision. And so some of the items that would help with that are computerized alerts and reminders, clinical guidelines, standardized order sets, patient data results and reports, documentation templates, diagnostic support, and clinical workflow tools. Now, as far as the actual CDSS goes, they could be standalone systems or they can be integrated within the EHR system. And there's two types. We have knowledge-based. If you read over on 295, they utilize inference software and databases containing the most current medical, scientific, and research information. Then your non-knowledge-based CDSSs utilize artificial intelligence that studies and learns from data and patterns of medical practice. But the most common are knowledge-based. Now you can look at the figure on slide 7 at the bottom of 295, and that goes over at the top of 296, and it talks about the 3 important components of a knowledge-based CDSS integrated within an EHR, and it's effective because of these 3 components. So the first is subjective and objective clinical patient data from the EHR. So this is the information that our providers and other clinicians have actually entered into the EHR system. So this is our medical record per se. Then 2, state-of-the-art scientific evidence and research. And 3, our physician or provider, could be a nurse practitioner, could be a physician assistant, but their knowledge, experience, and judgment. So the marriage of these 3 things will help the CDSS integrated within your EHR to be effective. So again, 1, subjective and objective clinical patient data, so your medical record. 2, state-of-the-art scientific evidence and research. And 3, your physician, their knowledge, experience, and judgment. Now, let's talk about the benefits of a CDSS, because there are several benefits of using a CDSS. Now, first, reduce risk of medication errors. Second, reduce risk of misdiagnosis. Next, increase direct patient care time for the healthcare provider. What healthcare provider doesn't want to have more time with your patient than sitting down at a computer, reading through a bunch of information? Next, access to state-of-the-art data, research, clinical pathways, and guidelines. Next, reduction of unnecessary diagnostic tests. faster diagnoses resulting in faster treatment, prescription for lower cost medications. So again, all of those are awesome benefits of using a CDSS, but there are some potential disadvantages. Now, one of the disadvantages is high cost of maintaining the CDSS with the up-to-date medical research, the clinical pathways, the guidelines, the medication cost, and so forth. Healthcare changes every day, so it is costly to go in and update this information on a regular basis. 2, potential over-reliance on technology. Now, this could be some of your younger physicians that are coming in and they have been part of that technology world. So instead of having the experience and having the judgment, they are more reliant on a computer system to diagnose their patient. Now, that's not necessarily a benefit. That could be a disadvantage. Okay, so going back on the other end of that, perceived by healthcare providers as a threat to clinical knowledge and skills. So let's say you got a provider that's been practicing medicine for 50 years. Well, he didn't start out in the technology world, but here we are with our EHRs and our clinical decision support systems saying, here, use us. We'll help you faster diagnose your patient. We'll help you treat your patient better. And he's on the opposite end of that young physician saying, oh, so you don't value my judgment. You don't value my experience. You don't value my knowledge. So it kind of works both ways. It's a two-way street there. And then last, harmful outcomes if software is not thoroughly and continuously updated. And that kind of goes back up to that high maintenance cost because you have to update this information regularly. If not, you are out of date within 6 months to a year, maybe even less. New drugs come out every day, new treatments come out every day, and it will not take you long to get out of sync with what's going on in modern medicine. All right, we're going to move over to most common users of a CDSS, or uses of a CDSS, The most common uses of a CDSS in healthcare involve clinical needs, such as alerting providers to possible drug interactions, assisting with the establishment of correct diagnoses, screening for preventable diseases, and assessing state-of-the-art treatment options. And so we're going to talk about each one of these things in Table 11.1, which again are taking us through the common uses of a CDSS. So first, we're going to talk about alerts. Now, this could be our drug alerts. It could be our drug-food interactions. It could be duplicate testing alerts. Hey, your patient's already had a CT of the head. Or it could be abnormal lab values. Now, if you flip over to 298, we're going to get into a phenomenon called alert fatigue. Now, anybody working in healthcare knows that every time you turn around, you have an alert popping up on a patient. Again, it could be drug, it could be telemetry, it could be lab results outside of a normal range. Now, your providers can get to where they ignore these alerts without studying each one because of just the volume that they encounter in their daily practice. Now, the consequences of alert fatigue may be life-threatening if they inadvertently ignore a serious alert. So, it says, to reduce the chances of alert fatigue, the thresholds of when an alert is triggered in the CDSS must be set at an appropriate level, which can be accomplished by defining policies regarding the types of alerts or types of results, whether you have normal, abnormal, or critical results. Medical staff should be instrumental in determining thresholds to ensure continuing buy-in regarding alert delivery from the CDSS. And then you have to have constant monitoring just to make sure that, providers are alerted when there are significant or potentially significant care concerns. Now, the next item on our list was diagnoses. So we're going to move on to slide 17 so we keep up with the book. So For example, it gives us a scenario here where a college student, he presents at an emergency department. He has high fever and stomach pain. He's got stomach bleeding, appetite loss, headache, weakness. And they do some routine lab, and it only reveals an elevated white blood count. Well, the patient's going to be admitted for further testing and diagnoses. So when the attending physician uses the CDSS that's integrated in their hospital EHR, it searches that patient's information. Remember, we talked about how it intelligently filters the information? Well, it suggested a diagnosis of typhoid fever. Well, it got that because of the symptoms that we just listed off, and that there was a documented recent trip to Kenya. Now, based on the suggestion from the CDSS, the attending physician agrees and orders a lab study for Salmonella typhi, and the results came back positive, and so then the physician was able to begin treatment. So the CDSS kind of pulls in all that information, and again, based on scientific evidence and research, it can then say, hey, I think because we have a high fever and we have stomach pain and we have stomach bleeding and we have a headache and this patient has recently been to Kenya, that you need to look into this. And so that's where you get those faster diagnoses and then those faster treatment options. And so again, following along with the treatment, our next section talks about how oncologists use the CDSS in their practice. They can review latest research trials for all types of carcinoma treatments and offer his or her patients choices if traditional treatment options are unsuccessful. So again, that was one of the benefits, faster diagnosis and faster treatment. All right, moving on to preventative care. Now, our example here of preventative care is if a physician practice has a high patient population with diabetes. The physician practice may routinely use the preventative screening aspect of the CDSS to identify patients at risk for diabetes. According to the American Diabetes Association, anyone with a body mass index above 25 who has additional risk factors such as high blood pressure and high cholesterol levels is at risk for diabetes. Therefore, a physician's practice may routinely run reports to identify at-risk patients, sending alerts via their preferred method of contact to ask these patients to make an appointment for a diabetes screening. Because again, we know that when patients stay healthier because they go for routine screenings and preventative care, then everyone's going to save money. The patient's going to save money. Healthcare facilities are going to save money. So again, that's how preventative care can be used through a CDSS. All right, moving over back to provider efficiency. Now, CDSSs can contribute to greater efficiencies for the provider. The hospital can incorporate the care plans for certain types of diseases in the system, thus making it easier for physicians and other clinicians to follow them and increase compliance with Medicare or accreditation requirements. For example, patients presenting with a possible diagnosis of pneumonia, the detailed instructions for the care of patients with this diagnosis, also known as the protocol of care, includes a chest x-ray and a blood culture within 24 hours of admission to confirm the diagnosis of pneumonia. Such protocols can be programmed into the CDSS, thus contributing to greater compliance with requirements, quicker diagnosis, quicker treatment, and possible decreased lengths of stay. All right, last we have cost reduction, and we don't really have a slide for that one, but it talks about how a CDSS plays a part in healthcare support in reducing cost. Patients become increasingly savvier consumers of healthcare, and they often are invested in keeping costs down. An example, a family physician who understands how important the cost of medications is to her aging patient population may use the CDSS to help select the best, most cost-effective medications covered by her patient's insurance plans. All right, moving on to meaningful use requirement here. Now, back in Chapter 1, we talked about high-tech, health information, technology for economic and clinical health, and it specifies criteria for meaningful use of EHRs. Well, clinical decision support is a requirement of an EHR system that meets specified meaningful use criteria. Now, each stage, 1 through 3 of meaningful use, requires an increase in the functionality of the clinical decision support component of the organization's EHR. Now, the final rule for stage 3 requires the demonstrated use of multiple CDSS interventions that apply to quality measures in at least 4 of the 6 national quality strategy priorities. And these 6 are 1, preventative care, 2, chronic condition management, such as diabetes, coronary artery disease. Number 3, appropriateness of lab and radiology orders. 4, advanced medication-related decision support. Number 5, improving the accuracy and completeness of the problem list, medication list, and drug allergies. And number 6, drug-drug and drug allergy interaction checks. Alright, so let's talk about the role of EHRs in quality improvement activities. So we're going to drop down to slide 25. And again, read the entire chapter. I'm not covering every word of this chapter. So, as always, read your chapter. We're just going to hit some of the high points with the slides in this lecture. Now, EHRs can play a major role in the healthcare organization's quality improvement activities, but the question remains as to whether the healthcare organization is fully utilizing the data available through the use of EHRs. Reporting capabilities in the EHR system provide healthcare organizations with important statistics and can help identify opportunities to improve patient care. A routine review of clinical and outcome data and statistics can assist healthcare providers and administrators to identify potential quality issues. Typical subject areas of statistical review and monitoring in an inpatient facility include infection rates, ventilator weaning success rates, length of stay, fall rates, morbidity and mortality rates, types and frequency of diagnostic tests per diagnosis-related group, and medication errors. A CDSS integrated with an EHR can provide statistics on many typical functions of an inpatient facility, so physicians, hospital managers, and other stakeholders can take necessary steps to improve areas in which the inpatient facility falls short. Now, typical areas of statistical review and monitoring in your inpatient or in your outpatient facility include mammography, diabetes and colorectal screenings, and routine physical examinations. A CDSS integrated with an outpatient EHR system can provide information on that practice's patient population, allowing healthcare staff to send reminders or schedule follow-up procedures. All right, moving over to page 302. Now, the Joint Commission took a major role in working toward improving health care in U.S. hospitals as early as 1999 and continued to roll out more standards and requirements for many providers of health care, with its biggest focus on inpatient acute care hospitals. The Joint Commission's ORIX program requires hospitals to gather performance data for the purpose of identifying opportunities for improvement in the services they provide. For accreditation purposes, hospitals are required to demonstrate data gathering, data analysis, and steps to improving quality of care. The Joint Commission has worked with CMS to develop a set of common quality measurements, which has resulted in the specification manual for hospital inpatient quality measures. This specification manual contains a data dictionary, measure information forms, algorithms, and other tools to be used by CMS and the Joint Commission. The goal of this common set of quality measures, of course, is to improve quality of care, minimize data collection efforts for these quality measures, and focus efforts on the use of data to improve the delivery and quality of healthcare in the United States. All right, moving down to the National Quality Measures Clearinghouse. Now, this is a resource regarding quality measures reported by all types of healthcare settings. These measures are available to the public by accessing the website www.qualitymeasures.ahrq.gov. It contains two major categories of measures that include healthcare delivery measures and population health measures. Healthcare delivery measures are measures of care delivered to individuals and population defined by their relationship to healthcare providers, organizations, and insurance plans. Population health measures are measures that address health issues of individuals or populations defined by geographic area. Now, the NQMC is a repository for quality measures and measure sets that healthcare organizations may choose to use for research, study, and or reporting. The NQMC does not gather or report on data from healthcare organizations according to these quality measures. All right, moving down to electronic clinical quality improvement. Now, the implementation of EHRs has significantly affected the process of data gathering and data analysis with the goals of improving the quality of healthcare, reducing the cost of healthcare, and making healthcare more accessible to all individuals. CMS and the Office of National Coordinator for Health Information Technology, the ONC, are working together to promote electronic clinical quality improvement, or ECQI, for the monitoring and analysis of the quality of healthcare provided to patients and patient outcomes. Now, we talked about these quality measures, these ECQI, we talked about this briefly in performance improvement. Now, some of the examples of ECQMs is found on page 303. They include home management plan of care document given to the patient or caregiver, primary percutaneous coronary intervention received within 90 minutes of hospital arrival, PCI administered to heart attack patients within 90 minutes of hospital arrival, and wait times from emergency room arrival to inpatient admission time. All right, and if you look on page 303 at figure 11.2, that's also in your slides here. Kind of looks like a chart that we would see in PI. Again, we start with provide care, then we're going to measure the results. We're going to look at the processes and outcomes. Then we're going to plan our improvements, and then we're going to implement our improvements. So again, PI is everywhere. All right, moving on to page 304. Garbage in, garbage out. Love this saying. So this is commonly used more in computer science, and it refers to computers that produce faulty output when the data input is inaccurate. Now, healthcare facilities suffer from this as well. They should create strict documentation policies and guidelines to comply with governmental, regulatory, and industry standards. Facilities should use a standardized format for healthcare documentation, such as SNOMED CT, to record diagnosis and create consistent templates in their EHR systems for documentation. Because again, just like in the computer science world, if you put garbage into your electronic health record, you're going to get garbage out of your electronic health record. So in addition to standardized documentation, any corrections of EHR data should also be handled consistently. Accurate data is important in patient safety, and it plays an important role in successful CDSSs. A CDSS of an EHR system will not properly function if entered data is not accurate. If a patient's medications are not entered into the EHR system, then the CDSS will not detect drug-to-drug interactions. If the patient's weight and height are not accurate, then the CDSS cannot accurately assess his or her risk for diabetes. It is crucial for healthcare facilities to ensure consistent and accurate documentation if they want a CDSS to provide its many benefits. right, moving over to clinical documentation improvement on 305. So, clinical documentation improvement, or CDI, is easily defined because the term describes itself. We know that clinical documentation is the information documented in a health record, and we also know that clinical documentation needs to be accurate, timely, and thorough. A program of CDI is the review and improvement of clinical documentation in a healthcare organization. Hospitals that implement a formal CDI process typically employ nurses or practitioners certified in documentation improvement. Now, a concurrent CDI program would result in higher quality of care because, again, concurrent means that the patient is still there, the reviews are happening real time, again, while the patient is on the nursing unit, and sometimes can resolve things before a patient even gets care. I know in the past at Tupelo, we've had a nurse to recognize sepsis in a patient, and that patient has not been given any antibiotics or anything. And so she reached out to the floor and told them what she saw happening in progress notes and in lab values. And she got that patient started on treatment rather quickly when at that point in time, nothing had been done. So, by implementing our CDI programs, more physician practices are reaping the same benefits as hospitals, such as better documentation, timely billing and coding, and higher quality of care. Implementing a well-organized and successful CDI program should be considered a requirement to all health information governance programs. Now, dropping down in that bottom paragraph, you can probably identify many areas in which using an EHR in the CDI process would streamline processes significantly. The health record is immediately accessible with the EHR. Queries can be sent electronically. The physician provider can add clarifying documentation into the health record immediately, and the coder can send an alert that the documentation has been added so that the coding function can be completed. CDI has primarily been a process carried out in the hospital setting, but again, these physician practices, they're learning. There's more and more movement toward outpatient CDI, and that's where those physicians start benefiting in the office. Okay, and then finally we have our chapter summary. So CDSSs play an important role in the EHR systems. Appropriate use of CDSS guides decision making to improve patient care, safety, and other operational factors. The most valuable benefits of CDSSs are those that improve patient care. And there are a variety of disadvantages, and they should be appreciated as providers and facilities adjust to using these systems. CDSSs must be kept up to date to ensure safe patient care and reduce the risk of liability. Quality improvement activities are enhanced when EHR data is leveraged. Data entered into the EHR must be of high quality to produce the best outcomes with CDSS use and statistical review related to quality improvement. And the implementation of EHRs has significantly affected the data process or the processes of data gathering and data analysis with the goals of improving the quality of healthcare, reducing the cost of healthcare, and making healthcare more accessible to all individuals. So again, be sure to read this entire chapter, read through your PowerPoint, know your acronyms and initialisms at the end of the chapter. Those are always good to know, not just for now, but for later when it comes time to take your RHIT. And so again, as always, happy reading and happy studying.